Thank you all for accepting the invitation today. So we are going to have this different webinar. I'm going to moderate this with my friend Ashvin. We're going to share the moderation. Hi, Ashvin. This is special webinar. We're going to talk about all the issues about the bag capsule dysfunction situation. Either you can preserve the bag, or you have a situation abnormality in the bag, or you don't have a bag. What can you do, and what you are going to replace it by different situations. So we have this webinar is sponsored by Eva Pharma, which is one of the biggest Egyptian pharmaceutical company in Egypt. Thanks to Eva for the supporting the continuous medical education. So we are going to start our webinar with poll questions. I'm going to put the polls for all the attendees and also for the panelists if they want to share in the questions. So the first poll question, which procedure have you understood at least? The glued IOL, the least, the glued IOL, the Yamani technique, the Canabrava proline scleral fixation technique, iris fixation suturing, or retropupillary IOL. So the people are voting, increasing the numbers now. 38, 44, 35%. We are reaching 40% of the audience. 53. Voting is coming. Okay. Okay. So 29% of the audience said Canabrava proline scleral fixation technique, and next is retropupillary IOL fixation. Okay, we are going to see in the presentation, maybe they change their mind after. Okay, the second poll. You are seeing the poll now?
No, it disappeared. Ah, yeah, it is.
So what is your technique in anterior vitrectomy where when there is a PCR and vitreous loss? Part planar vitrectomy, anterior approach, or according to the case? Voting is increased, more than 50% of the audience. Okay. Okay. Okay, we ended. So 76% of the attendee anterior approach, 10%, 12% only part planar, and others say according to the case, the 27%. Okay, the third poll, can you see it?
Yeah.
Yeah. So what is your IOL fixation technique in loss of the bag? AC IOL, glued IOL, Yamani technique, Canabrava proline scleral fixation technique, iris technique suturing, or retropupillary fixation? Voting is increased, more than 50% of the audience. Okay. Okay. So 30% saying AC IOL, and 27% retropupillary IOL fixation. Blue IOL is 14%, Yamani is 16%, Canabrava 9%, and iris technique suturing 5%. Okay, this will going to.
I mean, this is going to make this webinar very interesting now.
Yes.
Sergio will be given the baton to explain and make us understand that Canabrava technique, because I think everybody wants to know that technique, and I think it's a hot piece right now. So everybody wants a piece of that.
Yes, your talk, Canabrava, will going to be everyone are going to wait for it.
Right, that's right.
Okay.
That's right.
So
that's
Ashvin,
right.
Yes, Ashvin, your talk. Yes.
I think moving ahead, I think we wanted to introduce the first speaker for today to explain all these techniques. But first up, wanted to give an overview of what the topic is, what the problem is, and why this topic is a sure in everybody's OR. We all face this in everyday life. And I think no better person than Ashraf, who actually is the moderator, the mastermind behind this webinar, and the one who puts so much of energy and gives us so much of warmth when we come into these webinars. So Ashraf, want you to talk about your topic for the day. So take it off.
Okay. Thank you, Ashvin. Thank you for everyone for accepting the invitation. I'm going to start the webinar by saying to Brian, this is your day today in the States, so I wanted to put this for the front to welcome you here. Happy 4th of July, Brian. This is what I wanted to put in before I start my talk. And thanks for accepting this invitation in the holiday time.
Thank you.
So my talk today will going to be if we have a bag, how we can preserve it till the last of the situation. I have no financial disclosure regarding my presentation. This is my disclosure. So what is the aim of my talk? To reach the excellency masterclass in challenging situations, you must know what are the rules. These rules to decrease the deterioration when it becomes complicated. And it is not a shame that the complication happens, but the shame that you don't try to masterclass to know how to deal with them. What should you do when you have an open posterior capsule? Always keep your eyes on the posterior capsule in the last quadrant. These frequent situations happen when it is a shallow anterior chamber starts to decrease or there is a positive pressure. In cases of high hypermetropia with a small anterior chamber depth, post-glaucoma cases with narrow angle glaucoma or a leak on phaco ends, always keep calm and maintain your stuff around in a quiet situation. Never deny that you have an open posterior capsule. Never be in the reflex, taking out the phaco probe once you know. As you discover your posterior capsule opening, make all the parameters slow, including the bottle, and decrease the flow. Inject high viscodispersive OVD to maintain the vitreous and the anterior chamber depth. This will maintain your anterior chamber IOP and decrease the instance of prolapse and disturbance of the vitreous. Evaluate if there is a vitreous prolapse or not, and prepare all the tools and the type of IOL. So my first case, it was severe pseudoexfoliation before the scaling and after the scaling. So you have a tip in these cases. The rexus should be, you do it meticulously in a good size, because you can have the tear posterior capsule and you need to put the IOL in the sulcus, so it's captured anterior rexus. So proper rexus is very important, and proper size. And when I did the hydrodissection and during rotation, I felt that the bag is subluxated. So I take the decision directly to put the capsular hooks to maintain the bag integrity. And I finish, as usual, my phaco technique, chopping, stop and chop, then vertical chopping, and see how everything is maintained. The bag is stable with the capsular hooks. I can do it. It's a very hard cataract, but still, I don't feel that I'm afraid now, because I have a bag is totally supported. Your OVD is very important. You maintain your bag, because these bags are very flexible, and it's easy to come to you during the phaco. Always maintain the pressure. Don't go out with the phaco probe. This is one of the tips in these cases. Use your left hand, can do anything, but your right hand with the phaco probe, don't go out of the eye, because going out, you are going to change the pressure. Letting the bag can move frontally and can lead to more zonulosis. See how the IOP, the pressure in the eye is maintained. I can finish the situation easily, because the bag is totally supported now. It's very hard, and I can have the bag preserved for an implantation inside the bag. But in this situation, CTR is very mandatory. After you finish, see, I didn't remove the capsular hooks till now. Removing all the cortex. Putting the CTR in this situation is very important. And as all you know, that in the last injection of the CI, you must protect it not to flip outside. You put your single piece IOL inside the bag, and you remove your hooks, and you preserve the bag in these subluxated cases. So my key points here is early detection of zonulosis is in hard cataract. Capsular hooks is a life-saving, and also CTR is mandatory. My second case, it was a very hard cataract, also in a white cataract. And I did a mistake. You are going to see it now. During the division of the nucleus, it was aggressive. You see it now. It was aggressive. I felt that I did a mistake. So all the operation, I was taking care to look carefully for the posterior capsule, because I felt I did a problem. During rotation, I feel that the nucleus is not rotating well. There is something wrong. I can feel it now. But still, I said to myself, no, everything is fine. And this part, I took this piece, rotation, and at this point, when I take this part, you're going to see it now. I make it slowly motion. See, there is an opening in the posterior capsule. So I took the decision, either I do anterior vitrectomy or parasternal vitrectomy. My decision in this case, I do it anterior vitrectomy. I didn't do the posterior vitrectomy. So I slow motion everything. I put a viscodispersive, very important, not to disturb the vitreous, but still there is a vitreous band. So this aim is to do, I did the vitrectomy. In this case, I go inside the hole to the vitreous. take some vitreous. So see, you cannot see the opening now because I removed a lot of vitreous bands, but still there is some vitreous band. So I continued very slow. I didn't do dry, but I continued with the very slow parameters. I remove all the cortex, even in the area of the capsular opening, because this is a very slow parameters. Injecting visco-cohesive in this time to put a single piece, even in a posterior PCR, but because you didn't disturb the vitreous too much, you succeeded to put it. And this is how the case post-operatively, second day. So my key point here is a mistake during cracking. This is, you should notice, be alert to detect the problem when it happens and prepare your mind for all the solutions to deal with the vitreous. My last case is a traumatic cataract, penetrating traumatic cataract. On the still stamp, I can see that there is an opening here. This is a big opening of the anterior capsule. And once you see this big opening, you should expect another opening in the posterior capsule. So visco-cohesive, should I read the pupil and see how is the situation? This is the opening. This is a huge opening of the anterior capsule. And you should, I was planning to also to maintain the back. Staying under the visco OVD, nothing easy, but I succeeded. I stayed mainly the part of the anterior capsule remnant. I want to enlarge the rhexis as much as I can and leave the part fibrosed, because what I made small snip of the anterior rhexis, of the anterior capsule. Then I continued my rhexis slowly. And at this point, I felt that I can't go beyond. It's a totally fibrosed part of the rhexis. Double way, I didn't use the bimanual because I don't need too much pressure. I used the double way cannula. And you are going to see, when I finish this part, you are going to see the opening hole in the posterior capsule. I need this part, so I did opposite opening of the other side. See the opening? I see the opening now. So I injected visco disperser, not to disperse the vitreous, because there is no vitreous at all. There is no vitreous at all. I did another opening in the other side to remove the residual soft matters, the cortex, with the double way. I succeeded to remove most of the cortex. And I found that the part of the anterior capsule is fibrosed. I didn't want to cut it and enlarge it because I felt it is a good support in case I didn't succeed to put the single piece in the bag. So before I go out, I injected also a visco disperser. Before you go out with the cannula, yes, I injected also visco dispersive to maintain the vitreous, visco cohesive to elevate the two leaflets of the anterior and posterior, and I put a single piece also inside the bag. Instead, you have an opening posterior capsule because you continue maintaining the integrity of your bag. Don't do too much manipulation in complicated cases. And this is how I felt in the end. And you see how the IOL is centralized, and you can see the Purkinje image is central in the IOL. I close all that because this is a child 5 years old. So in my key points in this, assess your sight and size of the anterior capsule opening, be alert to detect the posterior capsule opening, and preserve your bag as much as you can. For sure, I injected subtenon steroid because this is a child and this is a traumatic cataract to decrease as much the inflammation, and see how the Purkinje image is centralized and the IOL is central in spite of the opening of the anterior and posterior capsule. So my take-home message is the best anatomical and physiological place of a posterior capsule, PC IOL is inside the bag. to give the best vision for the patient. So do not lose your posterior capsule easily. To do this technique, you need a good microscope with a good depth of focus and high magnification, good instruments with a plenty of viscoelastic dispersive type, and a good amount of patience. Thank you so much.
Thank you, Ashraf. I think that was brilliant. I think excellent cases that you've shown there, and I think the way you handled it was phenomenal. I would have to add actually, you make it look easy. Okay, so a lot of people over here might want to know a little more finer nuances on that. But I'll start with a question, and I think we have about 3-4 minutes for 2 minutes, or 2-3 minutes for questions.
Yeah.
So I think I'll start with the question. In these cases of bag, let's say a case is more of a progressive condition, let's say a pseudo exfoliation or something like that. What in those cases do you do? Do you retain the bag? Because I know you like, all of us over here like retaining the bag as much as we can. But and we'll talk about the situations later. But what do you do in those situations where the bag is progressively zonulopathies, pseudo exfoliation, Marfan's, and so on and so forth? Your comments on that?
In this case, pseudo exfoliation, if I felt after removing of the capsular hoops that the bag is not in a good state, I'm going to put a 3-piece IOL in the sulcus. I'm going to make an anterior capture. This is I'm going to do it. If I felt that the bag is completely subluxated, so I'm going to put a segment suturing to the sclera for sure. I'm going to preserve my bag also. I rarely remove the bag unless I feel that the situation is very difficult and the vitreous is coming, there is a posterior pressure, I can't do anything. So in this is the only situation I'm going to remove the bag, do a proper anterior vitrectomy, and choose either Yamani or good IOL.
Anybody from the panel wants to comment on any other way that they handle that situation in a progressive condition?
I'll go ahead and make one comment. I think at the least putting a capsular retention segment is essential, I think, because if you're going to have a single piece lens, if you have at least a CTR, you can do later on suture fixation of the sclera with Gore-Tex, or now with Sergio's technique, you can try to use proline suture to do the same thing. So I think it gives you a mechanism of late dislocation, a way to stabilize and secure the bag.
Right. Thanks. Lukan? Yeah.
Lukan.
I want to comment on the second case. It was beautifully managed, and just a slight advice: you can continue to use the vitreous cutter to aspirate without changing to the aspirating handpiece. Just switch off the cutting and it will be more easier, but it was perfectly done.
Yes, I use this is true, Lukan. I sometimes use this technique to change to between the cutting and the aspiration, not to make too much manipulation inside the eye. This is true.
One point maybe that I would also like to say here is, in continuation with what Brian said, that one thing that I like to do in these cases is, sometimes in these subluxated cases, generally, if I'm putting it in the bag, I like to put in a 3-piece IOL for the same reason that if it goes in for a late subluxation with time, it becomes very easy for me to take that IOL and convert it into a glued intraocular lens, or, a Yamani if someone would like that. So that lens really takes away the need for me to do more intraocular maneuvers like intraocular cutting and explanting an IOL, and makes the whole procedure really, really simple.
Totally agree.
Priya, Sergio, what is your comment on, I'd like to ask you comment on the anterior vitrectomy or pars plana vitrectomy. I mean, we all might get a small tear or a small PCR. Any comments on that? What is it that you do?
Well, for me, I would like to say that if it is a very small thing, like what Ashraf had probably in the second case, there was a little bag which had just come up. So in that case, maybe a localized anterior vitrectomy would work, and then you would just inflate the bag and then it goes into position. But if it is a big tear, or if it's quite central and all, I would then prefer to do a pars plana vitrectomy, because then that's a point where we need to cut down the entire vitreous, and we do not want any more vitreous popping up into the anterior chamber. So yes, it's often it's a mixed approach that is taken up. It also depends upon the type and the location and the size of the opening that is present. But ideally speaking, pars plana should be the choice in almost all the cases. Sergio, what do you feel?
I thought a large PCR. I prefer posterior vitrectomy, and part you can do anterior vitrectomy with a new incision. I agree with Priya.
Can I
Lukan,
comment?
yeah, go ahead.
Actually, I'm against posterior pars plana vitrectomy. I'm a vitreoretinal surgeon, and if I'm going to preserve the capsule, I will do that from anterior way. If the capsule is unsavable, then we go posteriorly, because when we go posteriorly, we will disrupt the base of the vitreous, and it might lead to different complications.
Yes.
One quick comment on that case number 2, I think. Do you think maybe if you just isolated the hole or the tear with dispersive viscoelastic, you could have been able to spare doing the vitrectomy? Because sometimes I understand why you did the vitrectomy, but unless it actually presented itself, I don't know if it was presented or not. If the hyaloid face is intact, you should be able to continue to do the case without having to do the vitrectomy until a little bit later. That was my only comment.
Yes, I put some visco dispersive before I do the irrigation aspiration, but I felt there is some strands of the vitreous, so it makes me continue.
So one thing that I would like to add probably is that whether you go anterior or posterior, one of the really important things to do is to stain with IVTA, because that really makes everything clear about, even if do you have a vitreous prolapse in the first place? We do have it. Have you cleaned it up completely? Have you removed all the vitreous? Are there any vitreous wicks that are going to the wound which still need to be removed? All these things become so much more clearer if you've got IVTA staining in place in the first place.
Okay, we should keep moving on. So I'm just going to ask one quick question to Ashraf, because I think that's come in from the question and the Q&A. What's your input about using an anterior chamber maintainer in these cases? And then we'll move on.
Anterior chamber maintainer in cases of open posterior capsule.
Yeah.
I'm not going to do this. I'm going to, if I put a trocar, I'm going to put it posteriorly, not anteriorly. If I want to do a posterior vitrectomy instead of the anterior approach, pars plana, I mean, but I will not going to put an anterior chamber maintainer, because I want to decrease I decreased all the parameters. Once I see this, the main step, not to disturb your vitreous, don't make a turbulence of the anterior chamber.
Sergio, Priya, would you do anything different? Soosan, would you do anything different?
You want to go first, Sergio, and then I can go if you want. Okay, what probably I would like to say here is that we do sometimes use the anti-chamber maintainer. I think it's a very nice way to kind of not have to go in pars plana but still have continuous infusion going in. And one of the problems that ACMs we all know is that it keeps coming off when you're doing surgery. And there was this technique that Dr. Agarwal described, which is basically the trocar anti-chamber maintainer, where you can just put it in there through a trocar in a tunnel fashion into the anterior chamber, and that kind of keeps it in place and gives you continuous infusion. Advantage is, even if you're not used to putting it in pars plana, it still becomes a very easy way to have infusion there in place. So that's one thing. Now, the other thing is that when you have, if you're doing a glued IOL or Yamani or anything, if you're going to make sclerotomies, remember that it's always important to have infusion going into the eye in those cases. You don't want, you've done some amount of vitrectomy, the eye starts becoming soft, you've got sclerotomies there, they may start bleeding and you can get intraocular hemorrhage, vitreous hemorrhage and things like that. So at that point of time, it's important that you don't let the eye go into hypotony. Some people use viscoelastic to avoid that. I prefer using an anti-chamber maintainer with infusion. and that gives me better control over the eye.
Perfect. Thank you.
So we should move. We should move to the second speaker. Now, Lukan, show us how you can, if you have a torn bag or you are going to remove the bag, how you are going to do an iris fixation IOLs in absence of the capsule.
Now, is it my screen shared?
Yeah, clear.
So this is a case when the anterior capsule is unsavable, and this is late subluxation with fortunately soft simmering ring. And I try to, and I like to free the lens and back complex from the vitreous, and I rather prefer to lend the lens to the posterior pole. Then I clean all the vitreous in order to not create any additional peripheral breaks, which can lead to retinal detachment. And after cleaning everything, I can use PFCL, or you can do that without PFCL, but you can damage the macula, because when you clear the simmering ring and the remnants around the lens, it will fall at least a few times on the posterior pole. So it's safer to have a cushion in form of a PFCL behind the lens. So often these are old patients, and these lenses are old also. So before cleaning the IOL, you cannot know if the lens is actually usable. You can see here that the haptic is already suffered some damage during the implantation from the anterior segment surgeon. So probably here a Yamani technique wouldn't be the best choice, despite the lens is 3-piece, because this is, by the look, I can guess it is MA60, and these are PMMA haptics and can easily broke or disengage from the optic. And my choice of fixation here after cleaning the lens would be iris fixation. Why? Because in elder patients, the endothelial cell count is physiologically already low, and I try to be as safe as possible for the cornea. So possible explantation procedure would damage the cornea additionally. Now, when I lift the lens with my crocodile forceps, I will use a micro grasper from anterior chamber to reposition the lens over the iris and in a position which will be convenient for me for iris suturing. So the 3-piece lens is really comfortable for that. I'm using a Sipser sliding knot for that. It's a same as mechanical. So the aim is to pinch the iris in mid-periphery. That way you avoid the small and the larger vessels of the iris, and the positioning of the IOL can be well controlled. In that case, the lens is turned around, but MA60 is spherical lens, so there is it doesn't matter which side of the optic is facing the cornea. As I said, at least as maneuvers you can do in the anterior chamber is better for the endothelium. So this is the sliding knot. I like to use 10-0 Prolink suture. At least 4 knots should be done in order to have a stable fixation. I use a spatula to guide the needle because you can catch a lamella and it is really annoying. Now you can see how you pass under the haptic, and the needle is 14 millimeter, so it's really long one and convenient for this type of job. I like to use my hook, which is horizontal, and it's really good in catching the internal suture. Again, the Sipser sliding knot. And as already pointed, we have infusion in the eye because it shouldn't be soft. Now, the upper haptic, the good thing with the 3-piece IOL is when it is iris captured, it self-centers. Now, you cut the remnant sutures and just push the optic behind the iris. I choose this technique in elder patients, actually. And I always do a peripheral iridotomy because no matter the vaulting of the lens or the position of the lens, you can always have a block. Now this is another case with single piece IOL. By the look, it is Technis IOL. And here you have a drop pieces from nucleus and tough vitreous around the lens. So I just want to add that it is good to not try to fish out the lens from anterior approach, but to release the lens from any vitreous, and then you introduce it to anterior chamber. So this is a single piece hydrophobic IOL, which again can be sutured to the iris in elder patients. There were some concerns for iris chafing or Uck syndrome, but I haven't seen that in my practice. And recently I talked with Ahmed on the matter, and he also doesn't seem to find a problem with such fixation. Why? Because the lens is fixated to the iris and doesn't move. So it's completely different than a single piece IOL in the sulcus. It is fixated on the iris. Again, the Sipser sliding knot technique. Again, the horizontal hook. I like to introduce the optic now behind the iris because I know that I have catched with the suture the lower haptic, which is behind the iris, and that way the optic will center the IOL according to the iris center. This is the one suture. I do it 3, 1, 1, 1. So only the first one needs to be 3 throws. And one advice, don't tie too much before centering the upper haptic, because often you can have a cat pupil. So if the sutures are not tight before readjusting the pupil shape with micrograsper, you can relieve a small amounts from the iris which were kept with the bite with the needle. So you tight the knots at the end. Now the same suture on the other side. Then you cut them with micro scissor. Again, peripheral iridotomy. And I believe this is a good technique for elder patients But actually now I'm doing Carle-Valle scleral fixation, which is something new, and I believe it's better. And that was my cases. That were my cases.
Thank you.
Thank you, Lukan, so much. It's very interesting. And just one comment on your, it's very lovely that you do the video editing. You put two screens and you enlarged one in the edge of the screen. This is very nice. You are showing your technique and highlighted by the other video. This is extremely professional. Extremely professional. And the other one, how you were so patient that you remove all the bag and the cortex of the IOL and keeping the IOL in the first case clear till you bring it in front and you fix it. Extremely perfect.
Lukan, there's a question for you. What about the slit shape of the pupil once you finish the iris fixation? And that happens, but what do you do with that and do you correct it?
As I pointed, I don't tie the knots before. I can pull the edges of the pupil to restore the oval shape. I agree that sometimes you can end up with a cat-shaped pupil, of course, but in time you develop a fashion to round the pupil.
Do you find that you sometimes face transillumination defects because of the suturing? Sometimes does it happen? Or?
Actually, very rarely, and it is related to the intraoperative manipulation. It is not something that happens later, in my experience.
Fine. There is one more point on this. How do you treat or how do you deal with in cases where the iris is friable, it's cheese wires out, and do you do that, or what do you do in those scenarios? I mean, you can't even put an ACIOL in those ones, but
no, I'm completely against IOLs, and they were doomed by Binghorst, as I remember, which was the inventor of them. So I don't like them at all. And when I see that the iris is, there is no potential to support the lens, I would just go to a scleral fixation of Carle-Valle lens or something like that.
In the second case, Lukan, did you fixate the single piece IOL in the iris?
The single piece IOL was fixated to the iris, yes.
Yeah. You don't see, there is no iris shuffling in these cases?
No, because the lens is fixated to the iris and doesn't move. But if you leave a single piece IOL in the sulcus, it will continuously move and shave the iris.
Just want to put to high point this because there is no movement of the single piece. It just fixated to that.
Yeah, the only issue you can face is Uck syndrome, which I admit happens like 1% of the cases. So you can choose that in elder patients when you judge the risks from the benefits. You can do that. 1% is the chance to have a Uck syndrome.
And no need for peripheral iridectomy in single pieces IOL?
Oh no, I do it in every case. Every case of iris fixation, peripheral iridectomy.
Okay.
Lukan, there's a question, and I wanted to ask the panel, does anybody else do iris suturing fixation techniques in their cases?
Oh.
Okay. So I'll just ask Lukan then in that case. In case of pseudo-phacodonosis, is that a problem in iris fixating in a vitrectomized eye? And this is a question that one of the audiences asked.
Yeah, I suppose who asked the question. If the eye is vitrectomized, there can be a movement of the iris diaphragm with the lens. So probably there I will choose Carle-Valle lens.
I would like to comment when fixing a single piece IOL to the iris, the formation of UG syndrome is possible. I met in practice. Basically trying to say that UG syndrome is actually possible. It's a comment. Could we use methyl cellulose only? Is a comment. I'm not sure if this is meant for your presentation though.
Okay.
I don't know that. Okay. Just going to move on then. Thanks, Lukan. I think that was brilliant cases, and I think the first one was just exceptional in its own way, that you retained the IOL and were able to maneuver that into fixing the iris, fixing the IOL to the iris. Fabulous.
Thank you.
Ashraf?
Yes. Now we are going to move to one of the talented surgeons, Priya from India. She's going to talk about the glue technique, IOL, as one option of the situation that we don't have a bag and we want to fixate the IOL to make the patient pseudophakic, not aphakic. So go, Priya, please.
Is this visible?
Yeah, very clear.
At the outset, I would like to thank Dr. Ashraf and Dr. Ashvin for having me here in this. And I have been entitled to cover up the glued IOL technique. So, and I'm very glad to do that. So thank you so much for having me here with all of you. So basically, I'll be just highlighting on this technique, and I'll be just going through what are the essentials for doing this procedure. So the basic essentials for an intrascleral fixation is, we need a 180-degree axis marking, we need good amount of vitrectomy, and we also need a 3-piece intraocular lens. So these points are valid for both glued as well as Yamani method. So going in for glued, the tools and instruments that we need end opening forceps with fine serrations, and we also need fibrin glue to seal the flaps in these cases. So I'll just go through some of the animations that I'm just trying to show you here, that this is a case of aphakia, and then what you actually need is fluid infusion inside the eye. And as has been previously mentioned, you can use an anterior chamber maintainer. We have a Trapar anterior chamber maintainer. You can also use a posterior fluid infusion from 3 millimeters, as we do it from the pars plana side. So that depends upon the surgeon's choice, but fluid infusion is a must. Going ahead, the next step would be having 2 partial thickness scleral flaps that you see here. There are 2 flaps which are 180 degrees opposite to each other. And once you have made these partial thickness scleral flaps, you need to make a sclerotomy that with the 22 gauge needle. That is what you are seeing here beneath the flaps. Sclerotomy is to be made at the proposed site from where you are going to get your haptics externalized. So having made these sclerotomy sites on either side, which is 180 degrees apart from each other, then you just load in with the 3-piece intraocular lens, and with the end opening forceps that you are seeing here, you are injecting the 3-piece intraocular lens inside, and then you catch the tip, and then you externalize the leading haptic, and you are doing a maneuvering for the trailing haptic, which is going on, because then comes the externalization for the trailing haptic. Then you have both the haptics which are externalized on the either side. Once you have these haptics on either side, you need to now tuck these haptics, and that is where you create the pockets, which were originally described by Dr. Gabor Shariat. So you need to tuck these haptics inside the scleral pockets that have been created. And then this is the tucking. Tucking has to be done quite well, which I will just highlight when I showcase the video. Tucking is the most important part, because then it helps you to give strength to the intrascleral fixation with the glued method. And then you put in the glue. Glue is for sealing up the flaps, and it prevents the postoperative hypertony in these cases. And once you have sealed up the flaps, you just use that glue to seal up all the other incisions all across. So that is the basics which I tried to get in with the animations. Now I'm just going to show you a very simple case. This is a case of aphakia. I'm not showing anything great here, but I'm just showing you the basic technique. This is a referred case which had come up, And what you can see is the air bubble inside the anterior chamber. The best part of the surgery was that the surgeon who had referred this case, had made all the incisions taut, and then this case was referred. And the surgeon had also done a little bit of vitrectomy in the anterior chamber, so that we did not have any vitreous which was coming out from the corneal incision of the phacosurgery that had been framed. So now what you see here is that, the marking, which is there 180 degrees opposite each other, followed by making of two flaps, which are the partial thickness scleral flaps and the fluid infusion. Here, a simple anterior chamber maintainer has been used. And then after making the sclerotomy site, vitrectomy is being done. Once you have cleared up the vitrectomy and you have done the vitrectomy in the pupillary plane and the anterior chamber, you just make a corneal tunnel incision. And this is a side port incision. We always make a side port incision because we also need at times, maneuvering the haptics. So it always comes in handy. So with the end opening forceps going in from one of the sclerotomy sites, the 3-piece intraocular lens is being unfolded slowly. Once the entire intraocular lens unfolds, the tip of the leading haptic is then pulled. You have to wait for the entire IOL to unfold. Before that, you cannot just pull the intraocular lens because it creates undue stress and tension inside the eye, and it might even distort your haptic. So having done that and you have pulled the trailing haptic, I just try to do the no assistant technique, which was described by me. In the no assistant technique, the surgeon does not need anybody else to hold the leading haptic, and it does not tend to slip back inside the eye. This is a suggested reading, which you can just go through that, which was described in the Journal of Cataract and Refractive Surgery. So after that comes the externalization for the trailing haptic, and what we just saw was the handshake technique, wherein the haptics are just being transferred from one hand to another. Again, you need to just catch the tip of the haptic, and then you need to externalize. So, and when you pull this, when you have both the haptics externalized, you are quite safe that, okay, you do not have any tendency of these haptics to slip back inside the eye. And what you now see here is the haptic tuck, which is being done into the scleral pocket that is created with a 26 gauge needle. In spite of doing many things at times, what you can see here is, there is a slight haptic kink that you are seeing here. Now, this is a very tricky situation. What I'm now trying to do is tuck this haptic inside, but that was a weak point from where I had just grabbed, so that the haptic from there it breaks. But the lucky part was that there was enough remaining haptic which was there, so the remaining haptic would be tucked inside. Otherwise, if you do not have any haptic left, you probably at times you even need to expand that entire intraocular lens, and then you need to use a new intraocular lens and then go ahead with the surgical procedure. So having done this, what you are just seeing is the placement of the fibrin glue beneath the flaps, and that is how the entire thing is sealed. And we always end up taking a corneal incision and sealing up the corneal wounds, no matter whatever be the clinical status, because these are vitrectomized eyes. And whenever vitreous is there in the anterior chamber, or you have handled, and in spite of doing even a good vitrectomy, always seal it up, take up sutures. There's nothing wrong with that. Always, you might not have the same situation when you are doing a glural. You might have eyes which have larger white to white diameter, and you might also have eyes which have smaller white to white diameter. The problem comes in when you are doing the intrascleral fixation with glued in larger eyes with larger white to white diameter. That is, I would just say maybe 13 millimeters or something of like that. So we just have adopted some variations for these eyes, because the normal surgical procedure, if you go ahead with that, you might not get enough haptics externalized on both the sides, and you might really not have enough amount of haptics to tuck into the scleral pockets. And if you really do not have that, your IOL fixation is not going to be strong enough. So for that, what we try to do is that, we try to do a peripheral iridectomy. But now where do you do that peripheral iridectomy? We do a peripheral iridectomy beneath the scleral flaps, at the proposed site of sclerotomy. Now, what actually is the concept behind doing this? That I would just come up to this. We described this in the Journal of Cataract and Refractive Surgery. Again, another suggested reading, because with a limited time slot, I might not be able to cover up everything, but then I would just try to show you here that what actually happens is that, when you have eyes with larger white to white diameter, we try to come up much more anterior By that, what I mean is that instead of making a sclerotomy maybe at 1.5 millimeters, we try to come up at maybe 1 millimeter or maybe 0.5 millimeters from the limbus. Now, this is a very tricky situation because then you might create an iridodialysis. If you try to come up much more anteriorly and doing a sclerotomy, the moment you go in, you might hit the base of the iris. So in order to avoid that, what we do is that we create a small peripheral iridectomy with the vitrectomy probe itself. So now what happens that from the point from where you really want to introduce your sclerotomy, when you want to externalize your haptics, at that point you go ahead and make a peripheral iridectomy so that you do not have any
strands in the anterior chamber are cut beneath the 180,
so that you do not really have any dragging of the iris tissue going on. So this is how what you just saw on either side, that peripheral iridectomy is being done beneath the scleral flaps at the proposed site. And now when you see that when the sclerotomy is being done, there is no dragging of the iris tissue along with it. And now what actually happens is that when you are doing an anterior sclerotomy, you are coming up much more anteriorly. The plane of the intraocular lens comes in front. So then what happens is that you get a lot of amount of haptics which are externalized on the either side. So I would just skip the remaining video because then it's just the lensectomy followed by the glued IOL procedure. So the advantages of doing a peripheral iridectomy when you are trying to do it in eyes with larger white to white diameter is that, anterior sclerotomy, it really makes it safe. The iris tissue damage is prevented and it enables greater haptic externalization. So, and on the reverse, if you have a small eye, there's nothing difficult in that because you will have much more haptics coming up from both the sides. In fact, you will have so much of haptic externalization on both the sides that you might have to even trim the extra haptic which you are getting it on either side. So, and then you go ahead with a similar procedure. So having a small eye is not going to be that tricky as compared to having a larger white to white diameter. So these are some of the suggested readings which you can just go through that. And if you need to go ahead much more with these are some of the books which highlight all these procedures. And it might sound interesting for people who are doing a lot of cataract surgery. Thank you so much for your attention. So this is what I would just cover up. This is my email ID. If anybody really wants to go ahead with any of the queries, you can just email me. Thank you so much.
Thank you, Priya. It's a very illustrative way to anyone to do a glue IOL. It's highly illustrative. The first part of your presentation, anyone wants to start a glue IOL, it's fantastic, really fantastic presentation. Perfect. You have questions.
Sure.
So, how far from the limbus do you do the sclerotomy entered in a glued IOL technique?
Usually it is about 1 to 1.5 millimeter. 1 to 1.5 millimeter is usually the recommended thing. But then when anterior sclerotomy is being done, or what I've said for larger white to white diameters, we try to come up much more anterior, quite close, like maybe 0.5 millimeters or something.
Someone suggested that you don't put an anterior chamber maintainer and you put a viscoelastic OVD to maintain the anterior chamber.
No, we don't.
Do you do this?
Yeah.
Yes.
No, we don't do that, and it's just not recommended for anybody to do this because you need to have fluid because for different reasons. First is to prevent hypertony. You cannot have you cannot do entire thing with an OVD because these are the eyes where there's you're doing a glued fixation. That means that you do not have any support going on behind. Whatever OVD you are injecting in the anterior chamber has to go behind, and there is no way that you are going to have a fluid you're not going to have that much amount of tonicity of the eye with the OVD. It cannot give you. So OVDs are only meant for small ruptures, sealing up them and doing a cataract surgery and finishing it off and all that stuff. But when you have to have this, I would just recommend that please use fluid infusion. That really helps you because multiple things are going on. And using fluid, it's a natural milieu of the eye. So I think that's the best thing that you can use.
Lukan, you wanted to say, yeah, please
yeah.
share your comment.
I have a question. Do you adjust your A constant somehow? Because this is really far ELP to the front of the eye, 1.5 millimeter.
Usually 0.5 diopters is what we do. But many a times we do it, many times we do not even do it because it doesn't matter much.
Mm-hmm.
Personally, I mean, I use the same procedure, but personally, I don't change the IOL power at all. Honestly, I have not changed my IOL. And it comes out to be perfectly fine, honestly.
Perfectly fine. Some people do it by 0.5 diopters. They do change it.
I just want, if you are doing this technique in a child and he's growing, and you trim the haptic in small eyes, you trim the haptic, and you tuck the remnant into the sphere. Say if you visit a child at 4 years with a friend, and at 10 years you find the eye is larger, you are going to remove the IOL and put another IOL?
I think that's a very tricky thing now, what you have asked. That, yeah, there's always a possibility of what you are actually saying. Scientifically speaking, yes. But actually, I've not encountered this situation. So maybe, but I've not encountered that.
I'll take this one. I have done quite a few number of pediatric glued IOLs now. And I think what happens is most of them, I haven't exchanged them yet. But the reason to exchange them is not the haptic or anything. It's just the IOL power, probably.
IOL power, yes.
IOL is probably the reason to exchange them, not the haptic. The haptic is perfectly secure, and I never trim my haptics. I never trim my haptics. I instead tuck a lot more. I mean, it's okay. What's the harm? It's just getting tucked. And if I'm just tucking in more, even if the eye grows, it's growing with it. I kind of leave it a little bit loose. Just keep it a little bit titrated out, so it kind of grows into it. That's all that happens.
I think there is no issue with child, because anterior segment of the eye develops completely after the 4th year, so it's only axial length. There is no issue.
The youngest case that I've done is 5 years old. Now that kid is almost like 9 to 10 years old. They're doing pretty fine with the same IOL, so it's going on well. So and as Lukan said, yes, the eyes, they are almost developed by that age. So yeah.
And if you want to change because of the power, it's very easy to remove it from the tucking and to put another one.
Yes, you can remove it, but then you can remove it.
You remove the side. You are going to remove the side of the tucking, or you are going to tuck it the same side. You are going to do different flaps?
It all depends. It all depends, because it might what might happen is that you might just remove those haptics and you might expand the intraocular lens, but maybe you might choose a different side to do that. It all depends upon the amount of the fibrosis that you have, because the haptic, that site is always open, but the flaps, you might have, if you have a lot of fibrosis, then maybe you might like to create with a new IOL a different site. You can just go diagonally opposite to that and then do that.
Ashraf, if you can dissect off the flap, then it's not difficult to explant a glued IOL.
Yeah.
The problem is with the flap. Otherwise, you can explant it. It's not really difficult.
In fact,
there's no trauma to the haptic. The haptic doesn't break off. Things like that don't happen. It comes out very clean.
Yeah.
In fact, I would go to suggest actually put some iris hooks and remove it from inside. You don't even have to open the outside. If you want to expand.
That's a good trick.
I always do this. I only just take it from inside and just pull it into the eye.
Yeah, correct.
It's so easy. It comes in like butter. Honestly.
Comes in. Yeah. The haptic, that tract remains open. Yes.
Yes, Lukan.
Just a suggestion or a question. Why we need to expand the lens, then instead of giving a contact lens and on 18 years to do a PRK and we finish this.
Yeah. Okay. Yes. It all depends upon the clinical situation and the other associated factors. This is just a discussion that in case if you have to do this, whether you can do that or you cannot do that. But yes, what you are saying is also there. We have to take many things into consideration and then go ahead regarding the decision that, okay, this is what to be done. It also depends how much refractive error or anything of that kind, how much you're having and how much you can correct on the corneal surface and how much you cannot. So I think,
Last question before we go to Soosan. What type of IOL you are using? Because this is what type? This is the Indian type, yeah? Because the cartridge. Because the cartridge is not the cartridge of the normal.
What you saw was the Bosch and Lomb one. but we don't have these intraocular lenses anymore. The B&L 3-piece is not there. Currently we are using the Abbott ones, the Johnson & Johnson Sensor 3-piece intraocular lens here, the AR40. Yeah.
Okay. So now we are going to move to a special topic. I am myself waiting to hear it from Soosan, because I didn't hear a lot from about supracapsular good IOL. She wrote the technique today on the social media. I tried to understand. I didn't get it. So I think I'm going to understand now from Soosan. Soosan, I'm so happy and honored that you are with us. Please, your talk.
Thank you. Thanks a lot, Ashraf. Is my screen seen?
Yeah, very clear.
Okay. So my talk is on supracapsular glued intraocular lens. And I must say at the outset that I do not have any financial interest in this topic. This is a technique that I described in about 2013, and I will show to you why it is so beneficial and something that everyone can possibly include into their surgical armamentarium. Now, this was a case, this particular case that I'm showing is one that was also chosen for the Challenging Cases Symposium this ASCRS. And the name is quite long, but I think it makes sense to all of us, especially all of us who are attending this webinar today, because we like the bag, we like separation. And by separation, I don't mean separation from that the coronavirus has caused for us, but basically separation from the anterior chamber and the posterior chamber and the vitreous cavity. So we don't like to mix up the vitreous into the anterior segment as far as possible. I definitely don't like entering the vitreous cavity if possible. I'm sorry. So this was a case. This case example is quite a nice one to show of a myope, a high myope of actually -23 diopter sphere. She had a previous history of retinal detachment and she had a subluxated cataract. Obviously, this is a cause of progressive subluxation. And because she's a high myope and she's had previous retinal surgeries and all, I do not want to enter the vitreous cavity as far as possible. I want to stay away from it. And of course, this is also a desirable thing for all patients as such. So what I'm doing here is something very different. What I'm doing is I'm creating lamella scleral flaps, just as you would do for a glued intraocular lens. So all that is exactly the same. I'm putting in a trocar antechamber maintainer, something that we had discussed a little while ago in this webinar. And now if you see, I am doing a rhexis. So what I'm planning to do now in this case is basically a phacoemulsification. So I complete my rhexis with microforceps. And we also publish this in JCRS. Do a cortical cleaving hydrodissection, and then you go ahead and do a subluxated cataract surgery, basically taking all the precautions that you would do in a case of subluxated. So I'm doing hydrodelineation. Take care that you do not extend the zonulodialysis anymore. Put in translimbal iris hooks to support the bag in the zone of zonulodialysis. And once you've done that, you've also got a golden ring, and you can go ahead and emulsify. If you want, you can prolapse the nucleus out and do remove the nucleus outside the bag, or if you want, you could do an in the bag chop. Cortex aspiration, gently, making sure that you're going oblique or tangential in the zone of dialysis. And once you've done the cortex aspiration as well, basically, now you stop. Now at this point, what I do differently is that I have loosened the capsular hook. So basically these capsular hooks have been loosened, and that makes the bag drop backwards or towards the posterior segment. Towards the posterior segment gives you some more space between the anterior capsule and the iris. And I also put in, if you just go back a little bit in the video, you can see me putting in viscoelastic in that space between the iris and the anterior capsule. I now make an ab interno incision entry sclerotomy under the scleral flap. You could also do this ab externo as you normally do, taking your needle horizontally, making sure it goes horizontally so that you're not nicking the bag. And then again on the other side as well. And now this is why I call it a supracapsular glued intraocular lens, because it's the same glued intraocular lens, except that it's being done over an intact bag. In a glued IOL, normally you would remove the entire bag and the capsule, whatever's left of it basically, or if you're doing it for a subluxated cataract, you would just remove that. But here, what you're doing is fixing that glued IOL over the intact capsule so that the entire separation between the vitreous and the vitreous cavity and the anterior segment remains intact. You do not enter the vitreous cavity at all, so there's much less chances of posterior segment complications. Again, you can see that I insufflated that space between the iris and the anterior capsule with viscoelastic. Again, externalize the trailing haptic using the handshake technique. Once that's done, you've got this IOL sitting very stable on top of a capsular bag. And in addition, you've got those haptics stuck into the intrascleral chariot tunnels, and that gives it a long-term stability that the glued intraocular lens gives. So remember, this is a case also of progressive zonulopathy, and that really makes it advantageous because you've got long-term fixation as well. You've reduced your chances of posterior segment complications. You've basically not entered the vitreous cavity at all. You do some vitrectomy under the flaps. You also put an IVTA to see if any vitreous had prolapsed. You can do this at multiple stages throughout the surgery. If you feel that vitreous has prolapsed at any stage, chain with IVTA and do an anti-vitrectomy when required. Close all the incisions well, and basically that's the end of the case. Close the scleral flap, of course, and also the conjunctiva with glue, fibrin glue on both sides. So that's the end of the case. I'll show you the post-op. This is post-operative day 1 appearance. There's a lot of glue on the incision, 6/18 vision. Here's post-op. The next picture that you see is post-op 1 week, and she was 6/6 part or 20/20 part. And you can see a very well-centered intraocular lens. The capsular X is there, an intact posterior capsule, and the patient doing very well. So what are the indications? You could do it in all cases where you want to maintain the barrier between the anti-segment and the posterior segment. So you're not losing that bicamerality, you're not making it into a one large monocameral eye, but you're maintaining the bicamerality of the eye. And this becomes especially desirable when you've got progressive zonulopathies and exact cases such as high myopes, Marfan's, megalophthalmos, history of previous retinal detachment, and so on. It helps you retain an intact posterior capsule. It retains an intact hyaloid face. It avoids vitreous disturbance. The only vitreous that you're going to be touching is that's whatever is prolapsing around the zonulodialysis. It decreases the incidence of posterior segment complications such as retinal detachment and cystoid macular edema, and it also provides stable long-term fixation. Now the question is, what happens if you get phimosis of the bag? There are couple of ways that you can address this problem. Yes, you can get a phimosis of the bag, and what you can do in this situation, or maybe I can talk about that during the discussion, and go back to my presentation for now. We published this, as I said, in JCRS, and also in numerous book chapters. The latest work, which was David Chang's book, where I wrote a chapter on this technique. And this is basically an illustration from that book, which shows basically the mechanism. You've done a phacoemulsification. You've got the empty bag here. So you're not putting the intraocular lens into the bag. Rather, you've made the sclerotomies and scleral flaps and the sclerotomies, and you've externalized the haptics one after the other through the sclerotomies. And you've got this bag now stable over in. You've got the IOL now stable over an intact bag. I'll just show you one more quick video. This was published in 2013 in my YouTube channel. And this is an interesting case because now this child is grown up. This was a child with aniridia. She's 9 years old. She was at the time of surgery. Zonules were intact but possibly weak. She had severe photophobia and glare, and the best corrected visual acuity was 6/60. And what I did in this case was basically the same thing, a sulcus fixated glued aniridia IOL or a supracapsular glued IOL, supracapsular ISHF. You could also do the Yamani in the same way, supracapsular Yamani. So this supracapsular technique really, I feel, has huge advantages, especially in higher risk cases. So here you can see this is a child. Of course, the anti-capsule is elastic. I go ahead and continue with the uterata forceps. Maybe I'll jump through the video a bit. I've done the capsular rexus, putting in an anterior chamber maintainer, aspirating the soft cortex with just a vitrector. So I've got all the cortex coming out here. And now what I do is, once I've cleaned up all the cortex, I do a posterior PCCC. And that's the PCCC being done. Let me skip a bit again. Once I've got the PCCC, I go and I'm going to implant an aniridia IOL, but I'm going to put it as a glued aniridia IOL. And also I'm going to put it above this intact anterior capsule. So the 20-gauge sclerotomy, this is an old surgery, so I've made 20-gauge sclerotomies. And for aniridia IOL, anyway, you need a larger sclerotomy. So here you can see it's going below the iris stump and above the anterior capsule. And the advantage, as of course seen here, is vitreous cavity and the anti-hyaloid face are intact. Those eyelets of the aniridia IOL need to be cut off. So I'm trimming them. You don't need them here because we're not doing suture fixation, but intrascleral haptic fixation. So both the aniridia IOL eyelets are cut off, and then you do the same thing. Basically, you introduce it, get the haptics out. You can see the first haptic is out. And we do the handshake technique for bringing the second haptic out as well. So that's the second haptic out. Now these are PMMA haptics, so you do need to be more careful that they do not crack. You can see that the whole IOL is being rotated now. So that's when you rotate it and get it into place. And make sure that the eyelids, the haptics don't crack. Scleral tunnel is suture. And let's just go to the tuck in the haptics. And basically the rest of the procedure is same. So here, this is the post-op appearance. And this was 6 months post-op. You can see the best corrected visual acuity improved to 624. But more than that, you can see the clear visual axis, good red reflex, a little bit of phimosis starting there in the child, but no photophobia and glare. And she was quite happy with her outcome. So the advantages in this particular case was that we got iris reconstruction and the anti-hyaloid phase was intact. We avoided the PCO because of the PCCC, and that's important in pediatric children. And we also got intact capsular zonular barrier maintained, which is important again for so many reasons to maintain the bicamerality of the eye. And the glued IOL technique also gave us long-term stability. And this is the 3-year postoperative appearance of the same child. We can see a well-centered, stable supracapsular glued IOL. And we did an Nd:YAG laser posterior capsulotomy later to enlarge the PCCC further. This is the anti-segment OCT of the child. You can see that those haptics tucked in within the sclera, a very well-centered and stable and an iridia IOL with no tilt. And you can also see here those leaflets, which are the posteriorly fused leaflets of the intact capsule, with the YAG also having been done. So I think with that, I'll come to the end of my presentation, and we can discuss any of the other things during the discussion.
Great, Susan. The technique is different, so different. But I'm going to ask you, because the same thinking, I noticed a lot of questions coming to you. Are you doing optic capture for these cases? Why you didn't do an optic capture?
Yeah, that's a good question, Ashraf. So basically, this all comes in as part of the discussion that I said that we could have on phimosis. You know, what happens if phimosis develops? So what you can do to prevent phimosis is one of the things that you said. You could either do intraoperative a PCCC, as seen in the second case, along with some relaxing cuts on the anterior capsule. But then that's something that you're doing intraoperatively, and you might end up with a vitreous prolapse, which then has to be managed. So a more sensible thing would be to go in the early postoperative period, before the capsular phimosis becomes too dense and really completely shrinks the bag. Early postoperative period, once a little bit of fibrosis has started to develop, you could put cruciate relaxing incisions on the anterior capsule and also make a posterior capsulotomy, which gives you much more stable conditions in which to do this. The risk of, vitreous coming out and everything is much more less when you do it in a closed chamber. So that's one thing. The second thing you can also do is to put in a capsular tension ring into that empty bag so that you don't get phimosis as such, and then optic capture that IOL. So that's the second thing that you could also do. So these are just basically options that you can exercise for in such cases.
Lukan, go ahead.
Lukan?
I have a question. I noticed that you make the sclerotomies from inside out, and the aim is like, again, 1 millimeter from the limbus. First, do you do them on 9 or 3 o'clock? And how you avoid the larger ciliary body vessels? And do you have any issues with bleeding?
So in my first video, I did inside out. In the second video, I was doing outside in. So you can do it either ab interno or ab externo. If you're doing from outside in, you need to make sure that you're going very horizontal and not downwards into the vitreous cavity. You can take it, your question is how to avoid bleeding. So that's basically with the, putting an anterior chamber maintainer. In both my cases, I had anti-chamber maintenance inside the eye, and that prevents that hypotony from happening. If you don't have hypotony happening, you're not likely to get any bleeding. So, and your entries are into the anterior segment. They're not going into the posterior segment. So that problem, you may have a little bit of bleeding, but it's not massive. It's very controllable.
And you do it on 9 and 3 o'clock, right?
It would depend. Again, if you're having a very large, eye, you could go vertical. If otherwise, normally our standard technique is generally 3 and 9.
Susan, there's a question. Where do you not use this? Where can you not use this particular technique? Let's say you still have the bag, but when do you not use this?
I would not use it probably when you don't have a good capsular bag in place at all. When you've already entered the vitreous cavity, a posterior capsular end, for instance. The vitreous has already been entered to. You're going to be doing a vitrectomy anyway. There's really no point in, trying to save that bag there. This would be useful in situations where you're having a subluxated cataract, where you haven't really entered the vitreous. There's really no big indication for entering the vitreous. For example, for the other option would be maybe to do a lensectomy. Now, if you do a lensectomy, you could have, because you're doing it in an open eye, I mean, not an open eye, without any support, of course, unless you do the glued IOL scaffold technique or one of the scaffold techniques. Otherwise, if you do a lensectomy, your nuclear fragments can just go down and fall into the vitreous. So now here you're doing the entire phaco with an intact capsular bag. The chances of nucleus fragment drop also decreases, and you've got stable long-term fixation. So ideal, the really situations where you would really want to do this would be, one is progressive zonulopathies. You could also do it in all subluxators. You would not need to do it in cases where you have already entered the vitreous anyway.
And what about intraocular lens power calculation in this? Does it change from the normal glued intraocular lens? Or
you could, as Priya had mentioned, bring it down a little bit, but you could also keep it the same. It's up to you. Normally, you could decrease it by about half a diopter, because you're in a more anterior capsular plane. I mean, you're a more anterior plane, so you could bring it down a little bit.
What about the tilt and astigmatism?
No, the tilt is not there at
more
all.
Anterior.
Beg your pardon? The tilt actually, Ashraf, is not there at all, because as such in glued IOL, your tilt is not going to be there if you're exactly the same distance from the limbus on both sides. That will get rid of any tilt. In this, in addition, you have got an anterior capsular support there and a posterior capsular support. So tilt is really not an issue in this surgery at all.
But
unless your sclerotomies are not at the same distance.
But it's a little bit anterior than the glued IOL. True?
That does. Why would that cause a tilt?
Okay. Does it affect the endothelial count?
No, because you're still in the posterior chamber. You're not in the anterior chamber at all. You're in the posterior chamber, so the endothelial count is not affected at all. It's like it would be, you don't get endothelial decrease in the posterior chamber phakic IOLs. Even though that's anterior to the lens plane. So that's not that doesn't happen unless you're in the anterior chamber. You've got a lens in the anterior chamber. You wouldn't expect a endothelial cell count unless the endothelial cell count decrease comes from your surgical manipulations.
Ashvin.
Any other panel from the panel? I wanted to know. You guys have also done glued IOL at some point during your this thing. Do you see yourself probably using this technique? I know that most of the apprehension that even the viewers would be having of doing the glued technique is probably vitrectomy, probably making flaps, and so on and so forth. But I think vitrectomy being the prior one, which people don't want to do, or anterior segment surgeons don't want to do, does this procedure actually help you move to glued intraocular lens in some way? Maybe not all indications, but at least some indications are definitely here. So from the panel, Brian, please go ahead.
I think it's a great tool because, for the person who's intimidated to deal with the vitreous, if you have an unstable bag situation, you have zonulopathy, and you want to provide a long-term, more stable situation, rather than doing, a CTR, a sutured CTS, and all these things, you could transition to a glued IOL technique, not have vitreous, have an intact hyaloid face, hopefully, and learn to build up your confidence in the process of doing the glued. And also you can feel more confident that, if you are not skilled or mess up in the process of the surgery, you're not going to lose the lens because you have some level of support. And so I think it's a great transition technique for people who are learning. Absolutely.
Sergio, you wanted to add something?
Yes, I would like to say that after Brian voice is like a storyteller news. Man, your voice like after talk about after you is difficult. Oh man. Oh, just it.
Priya, do you want to add anything to that, or we can move on actually?
Oh, I think we can go ahead.
Sure.
Yeah, I think one thing I'll just say here is what Brian said is absolutely right. That, you're doing this, there's no downside to it. So even if you're stuck and you lose the capsule or whatever, you already have the glued IOL flaps in place. You have the IOL which you planned for this. Everything remains the same. you just go ahead and, you go ahead and just do a glued IOL. So the downside to it is really low.
Susan, one last question and we're moving on. 1.5 millimeters behind is your sclerotomy, or does that change in this procedure?
You would actually keep it at around 1 to 1.5 millimeters, but you also need to kind of get a visual impression of where the iris root is and where you're going to be putting your needle. So it would be a little different in high myopes. It would change a little bit. So get that visual impression and go slowly. So that's why sometimes you would want to go ab interno rather than ab externo. Two reasons. One is you're sure that you're going in that plane. And second thing is that you know that you're not going to be hitting the vitreous chamber. If you're going ab externo, you definitely need to make sure that you're going horizontal. You don't go posteriorly, because that would cause vitreous break anyway.
Perfect. Thank you, Susan. I think that was brilliant. We're going to move on. Next up, we're going to have a very special Brian Kim talking to us about his version of the Yamani. I would call it the Kim Yamani technique now, because it's probably the most hit YouTube site on YouTube. So probably
this is true, Ashvin. This is true, because when I saw his technique, I got really impressed. You make it very easy. So it's really talented technique.
Well, you guys are too kind. I don't feel that same way. I'm amongst giants in this webinar, so I'm really honored to be with you all and all of my friends here. We've had, especially Susan and Ashraf, we've had shared some fun, exciting memories with each other. So here we go. All right, so I hope that you can see my screen here. Okay.
Yes.
All right, excellent. All right, so the title of my talk is Yamani Made Easy, My Modifications, but really that's not quite true. I should really say Yamani Made Easier, because there's no such thing as easy. I think all of these surgeons, everyone across the board, have made these surgeries look so easy, and the reality is it's not, and it's because they have exceptional skill, and not only that, exceptional experience. And so please, viewers, don't take that lightly, and hopefully this means that we will continue to practice and make ourselves better with each case. So this technique was developed by Shin Yamani. He won the 2016 Grand Prize at the Ceres Film Festival, and it's an intrascleral haptic fixation flange technique using double needles to secure a three-piece lens when there's little to no capsule support. The benefits are it's minimally invasive. There's no conjunctival dissection. You don't have to make any flaps or incisions or sutures, and it is in the posterior segment in a closer normal anatomical position. But there are limitations, like a lot of techniques. It's very difficult to thread the haptics into the needle, and the haptics can slip out. You can have decentration or tilt. Intraoperatively, you can lose the lens into the vitreous space, vitreous hemorrhage, suprachoroidal hemorrhage. Postoperatively, you can have corneal decompensation, UGG syndrome, iris optic capture, CME, retinal detachment, and that's, of course, a limited number of complications. There are more, of course, that can happen. And this is the original technique. My friend Steve Safran does it exactly the way Yamani does. So he's delivering the three-piece lens with the leading haptic into the angle, and he's going to tunnel the left side needle first, micro graspers through an incision across, and cannulating the needle with the haptic, doing the same maneuver on the other side through a paracentesis incision contra-incisionally, grasping the haptic and cannulating the needle. And he's going to externalize both needles and then cauterize the ends of the needles. So that's the Yamani technique, the way it's described. So just what I like to do is sit superior-temporally. I think it's easier anatomically. You have the nose is less intrusive, the speculum's out of the way, the eyelid is out of the way. And I like to make a 3 millimeter superior-temporal incision and a paracentesis 180 degrees away from the main incision. And so the problem with conjunctival marks, the problem is without the marks, it's difficult to achieve precise scleral needle placement. So you can have a higher risk for IOL decentration, as you see here. And so the way to get around that is to make the marks, but you have to make sure that the surface is dry. Place 2 marks at the limbus 180 degrees apart, as just like with the glued IOL technique. Marking is so important so that you have good centration. I like to go 2.5 millimeters posterior to the limbus and 2 millimeters at a right angle. So the left mark is a backwards 7 configuration and the right mark is a backwards L configuration. And you can see the red arrows are the point of entry for the technique. And has always been said already, infusion is so important because a soft eye is not good for manipulating the eye. And so you can do posterior infusion or an AC maintainer. A larger bore AC maintainer is better, so you'll have more stability. And I prefer to put the trocars in and make the incisions in early on. Otherwise, it's going to be a softer eye. Now, marking the conjunctiva is not sufficient because the conjunctiva is a mobile structure. And so it's important to keep the conjunctiva in the neutral position. In other words, you want to have the conjunctiva in the position that actually reflects your measurements. And so for the left side, I'm holding the incision with forceps. On the right side here, I'm holding the trocar. And so you're going to see this video that illustrates this point. The trocar is held with forceps to stabilize the eye. You can see the conjunctival marks are not distorted with the needle pass. And same here, the marks are not distorted. The conjunctiva is not moving around. And so the next point is bending the needles. The problem is the first haptic needle complex is going to be released into the vitreous space, and you don't want it to be too deep in the vitreous space and potentially harming retinal structures. And so you want to bend that first needle about 9 millimeters, and this prevents that needle haptic complex going too deep in the eye. The second needle is going to be left longer, which is 12 millimeters. And so this illustrates the point. The right side needle is the first needle, and it's bent 70 degrees and 9 millimeters from the tip. And you can see the bevel. The needle is bent so the bevel faces the approach of the trailing haptic. The left side needle is bent 70 degrees and it's full length, and the bevel faces the approach of the leading haptic. Now note that this is the opposite order as Dr. Yamani's original technique. So why should the second haptic be bent at the hub? Well, you can see here the left side is already fixated, but the problem is the right side needle here is bent too proximal. And so because of that, this prevents the trailing haptic from reaching the right side needle. So next point, docking the haptic. So the problem is the haptic is curved and the needle is straight, and this is why it can be difficult to thread the haptic into the needle. And so the solution is to take advantage of the bevel of the needle by docking the haptic on the bevel of the needle, and then don't advance it yet. You want to straighten the haptic against the bevel, make it parallel to the needle track, and then it slides very easily. If you try to push it when it's not parallel to the needle, then it will kink or break, especially if it's a PMMA haptic. And the second point is a haptic has to face the bevel of the needle to facilitate docking. The left side needle is facing away from you, and the right side needle is going to be facing towards you, but it's always facing the haptic. And remember, this is an important point too. With this technique, the haptic does not have to be parallel to the needle because you're able to create that parallel configuration by using the docking platform of the bevel. So the bevel up is difficult to cannulate, bevel towards, bevel down are all difficult, and this is because the needle is straight and the haptic is curved. So the easier way is to dock the haptic towards the bevel, flatten it out, straighten it out, and then you can advance the haptic into the needle. So the other problem with the trailing haptic, and everyone says this is the most challenging step of the Yamani technique, is because imagine the left side needle is already fixated with the haptic. As you're trying to grasp the trailing haptic to thread the right side needle, you have to move the entire lens complex towards the left. But because it's already engaged on the left side, the haptic needle complex, it opposes the forces. As you're trying to pull it to the left, the lens needle complex is pulling it towards the right, and it causes the haptic to turn, and it prevents that parallel configuration for the right side needle. And so you can see that here. Again, one of my earlier cases where I'm really struggling, the left side haptic is tethered to the needle, and so I'm really having a hard time threading the right side haptic to the needle. And so I wrote this technique up on JCRS, and what this, I didn't know if this was actually a beneficial technique. Maybe this is just in my mind, but when I started to teach this at the wet labs, all of my students, hands down, once I taught them this modification, were able to cannulate the haptic into the needle so much more easily. So I do feel like there's some truth to this. And so the concept is simple. You want to externalize the leading haptic through the contralateral limbal incision with microforceps, and then you place the trailing haptic within the incision in a U-shaped configuration. And so the apex of the U is a perfect place to grasp the haptic to thread the needle. And despite the haptic being near perpendicular, you can take advantage of docking the haptic on the bevel of the needle to straighten the haptic. And so this is so important because it keeps the lens stable. You don't have to worry about losing it. And it does give you better access to the trailing haptic. So this is a video showing this. So as the technician advances the IOL, the surgeon externalizes the leading haptic with microforceps. And then you sweep the trailing haptic to the right, and then hook the trailing haptic into the incision with a U-shaped configuration. The apex of the U is the ideal place to be able to grasp the haptic. Note the bevel of the needle is used to straighten and then advance the haptic into the needle. The leading haptic is then internalized with microforceps, placing the haptic in the angle, and then you dock the leading haptic into the bevel of the needle. And then you pull each haptic up, making sure that not too much of the haptic comes out, because this can cause too much of the lens to be pulled to the left. And then you do the same technique on the right side, and then internalize the haptics. So the benefit is by externalizing the leading haptic, it really secures the lens, and it does make cannulating that trailing haptic so much more easy. However, it does require a surgical assistant, and you do have to internalize that leading haptic after you're done with fixating the trailing haptic. So a few more points. When you do this technique and you go back 2.5 millimeters, in order to get a plano target, I do choose an IOL at a -1 based on your IOL calculation. This modification is a little bit beneficial to do it that way. And then you always want to prime the needles with BSS, otherwise you'll have a bunch of bubbles and it's very intrusive. Don't forget to perform a peripheral iridectomy, which has already been stated, and I agree 100% with everyone on the panel who said that. And last but not least, every case poses different challenges, so you want to block sufficient time, plan ahead, and you have to be flexible when you're dealing with these cases. So in summary, the Yamani technique has many nuances and technical challenges. I do believe my modifications do flatten the learning curve. And if you're really serious about learning it, you want to sign up for proctored wet labs. All my friends here teach at the wet labs, and they are fantastic mentors and teachers. We have a Simulize eye, which is an artificial eye in the US. And I don't know outside of the US, but if you can get yourself access to these fake eyes, I think it'll also help you practice, invest in the right instruments. And I kind of skirted the issue, but this technique is really ideal for the haptics that have polyvinylidene fluoride haptics, like the C2 Lucia 602 lens. If you don't have access to it, it'll be quite a challenge. And so I think the glued IOL is really an excellent technique. In my hands, using the stronger haptics is really very, very beneficial. And lastly, choose the right first patient. And I wish you all the best. Thank you so much for having me.
Brian, thank you so much. I think you made the Yamani more easy for everyone who was thinking that it's a very difficult. Yes, it's going to change the Yamani worldwide. I think so by this. You make it very easy, very simple. Just a question, you need a good assistant to screw the IOL, because I think you cannot screw the IOL and you bring the haptic from at 6 o'clock. You need a good assistant to screw this type of IOL. Yes.
Yeah, I mean, yeah. Once you externalize a leading haptic sufficiently, you could actually go ahead and take over with injecting the remainder of the lens. So yeah, but that very beginning part is important. Yes.
Excellent presentation. Ashvin.
Brian, that was an exceptional one, and I think it excites all of us to actually go back. At least excites me for sure to go back and try the Yamani again. The reason probably we don't do it much in India is because we don't have the availability of the PVDF haptic lenses, and that's actually a drawback. And I know that Zeiss is facing a big challenge. They have a backlog from US itself. So I'm pretty sure that nothing is going to be shipped in the near future, at least. Lukan has a comment, and then I'll ask a question. Yes, Lukan, go ahead.
I want to congratulate you, Dr. Kim, that you mentioned retinal detachment as a complication, because there is a lot of maneuvering involved around the vitreous. And I want to ask why we should keep both needles with haptics inside the eye only to look elegant when we remove them, or we can externalize the leading haptic safely outside the eye, then we go to the trailing haptic. And the second thing is, I had cases of broken and disengaged PMMA haptics from MA60, AR40, and there is no availability of PVDF CT Lucia in Bulgaria. I know that there is a Hoya model in Japan with PVDF haptics, but this is probably the main issue with Yamani.
I agree. If I was in your shoes, it would be a challenge to do this technique without the PVDF fluoride haptic technique, the haptic lenses. And so if I was in your situation, I would be doing glued IOL all day long if it was me.
Small question. Did you see in your Yamani technique, did you see any intrusion of the knot after some time? Some people now do a conjunctiva flap. They put the knot to the sclera, then they close the conjunctiva, not to have protrusion of the knot through the conjunctiva.
So first comment is, if you don't have a good tunnel through the sclera before you penetrate into the vitreous space, what will happen is, if this is a sclera and you go in with a needle like this, then and then you make the little bulb, well then, naturally it's going to go up like this and it'll protrude through the conjunctiva. But if you enter this way and then you go in, then the haptic tends to be, kind of like this. And so even if it's visible on the surface, you will not have late extrusion, or you won't have this situation. It has to do with making sure you tunnel through the sclera with a good, sufficient amount of space there.
Brian, there are two questions that come up. One is, how do you keep the angle right on both the sides? I mean, I know that in Yamani, the angle is such an important step to actually get the tilt completely off. That is one. And the second question is, and I think this is a question that's come up in the Q&A box, 27 gauge needle, because I think the 30 gauge needle also has seen a depletion in parts of the world. So 27 gauge needle, can we use? Why not? We'll just make the flange a little bigger. And these are the questions that come up. So any comments on that?
So the first question about the angle, Dr. Yamani actually developed a device or an instrument where you can have a consistent approach and angle, I think about a 20-degree.
Right.
But the problem with that device is it doesn't adjust for corneal diameter size, I think. So that's the challenge. I mean, the short answer is really experience and getting used to the maneuvers. You know, a lot of the maneuvers are so challenging. Sometimes that angle can fall at the wayside. And, you know, you're so focused on doing the technique right, and then you don't get that angle right. And then you put you're like, yay, I did it. And then you look and the lens is very tilted, you know? So it requires an attention to detail at all phases of the procedure. Regarding the question of the 27 gauge needle, I can understand wanting to use a 27 gauge needle. It should work. The concern has always been that the sclerotomy size is going to be larger and you might have the flange slip through it. But I think it's reasonable to do it that way. To be honest with you, since I've had access to the 30 gauge thin-walled needle, that's all I've been using. So I can't really comment beyond that.
Right. So you have a comment? Yeah, good. Susan?
Brian, yeah, congratulations, Brian. First of all, that was a terrific presentation, and it's a testament to your surgical skills, the way you broke that procedure down and made it look so simple. Like Ashvin said, I really am, you know, so impressed with that now, because I always used to think this is such a difficult technique to do, you know. But your trailing first really seems to be a complete game changer, in that it really makes it look completely much more easier now. I do have a question. How do you know how much you need to do that low temp cautery for? How big a flange, or rather, do you try to just adjust the size of, just get that flange and then stop with that, or do you try to also shorten the haptic at the same time on both sides? If you're not trying to shorten the haptic, you're just trying to get a flange. Okay.
I think that some surgeons have talked about if you have some decentration, as long as you don't have tilt, you could have some asymmetric bulb shrinkage, or you can alternatively, if you don't want a huge flange, you can go ahead at that point, cut the bulb and then start over. So if you have slightly asymmetric, if you have a slightly decentered lens, that could solve that problem, but only if there's no tilt.
But otherwise, what are you aiming for when you first start putting that low temp cautery? Are you just trying to get that flange and then stop at that? Or are you also trying to shorten the haptics a bit so that your IOL moves a little anteriorly, so that you don't have to do that, that dioptric power correction?
No, it's simply just to get enough of a mass effect so that it won't slip through the sclera. That's it.
Okay. And I guess it would be kind of playing around a bit too much, if you try to make it shorter and then you find that you've gone too much on one side and too less on the other side. So
yeah, it's not that finicky though. I mean, yeah, you could, but your point is well taken. But once you do it enough, it's pretty intuitive. You won't feel like you have to keep cauterizing it to get a big enough bulb there.
Lukan, you had a comment.
Yeah, just to comment about dioptric titration, Dr. Yamani had published a video using Aura device and adjusting the tension and length to correct the EOP. So it's possible. But if the lens is not tilt as pointed by Dr. Kim.
Perfect. Brian, thank you so much for that great...
I have one more question. Brian, do you find that the haptics kink when you do the intraocular maneuvers, or is it just simple?
No, once I've gone to this transition to this technique, honestly, the hard part for me with the surgery is no longer this part. It's about how do I get this dislocated lens with the giant Sommerings ring and it's dangling, in the vitreous. I have to get this thing out of the eye, So to me, that now is really the bigger challenge. And so that does make me feel more confident that I don't really get too anxious about this part of the surgery anymore.
Right. All right.
Thank you, Brian. I think that was brilliant in the way that you've mastered and showed your craftsmanship in this Yamani technique, and sure taught us all. Moving on to, I think, our special speaker tonight, Sergio Canabrava, who's taken the ophthalmology unit by storm. So let's actually hear his technique, which is very unique in its own way. Even though he will be modest and say, no, I've got my tips from Glued IOL and from Yamani and from everybody else in this panel, but actually it's his own technique. So let's hear it from him.
Thanks, my friends. I honor to be here with these giants on subluxated cataract. And let's try to answer the audience to increase my numbers. Okay, let me share it. Okay, can you see?
Yes.
Okay, today I will not talk about four flanged, I will talk about double flanged, and I will do a quickly review about the technique. Here my disclosure about this technique, and a quick review, quick historical review. I have the idea in 2016 after to see the flanged of Yamani. And why you have this idea, Sergio? Because in Brazil, you don't have Gore-Tex. The Gore-Tex is not allowed here in Brazil. Then I had only 10-0 polypropylene suture and this photodegradation. Then I had the idea, the first time I had the idea to use a simple polypropylene suture, polypropylene haptic to make the first double flanged. And then I published it in ophthalmology, International Ophthalmology, and received a prize for the first double flanged haptic in 2017. Then, late of 2017, I have the idea, why not to use a simple? And here the game changed. I think here the game changed because with it, I can produce an adjustable suture with a simple ProLen, $3 in each country of the world. Then, in 2018, I published it on ASCRS in a patient with Marfa, a case series that I published for the first time the double flanged. Then, late of 2018 and 19, I have the idea to do the four flanged first with a single piece PMMA and then with a 4 eyelets foldable IOL. Then, why it's changed the game? Only 2019, more than 5 surgeons publish different techniques using the double flanged suture. And then I like this. This was about Dr. Kashikian from Los Angeles. Here he did first a four flange technique. He published it in AAL this last month. And then he used the double flanged to fixate artificial iris in the eye. But I suggest him, it's possible to do it only with 4 points. Don't need six points in the eye. Then, but today, after this historic review, I will talk about my case that I won the prize on Golden Apple Prize in 2019, and I published JCRS, and 2 cases about microspherophakia. And the number 1, teach me about the number 2. Here's the number 1. My question for the audience: it is a real catalyst report, or is it a fake news? What do you think? Look the position of the crystalline. It's a fake news or a real? No, it's real. It's a real. You can see after the femtosecond, after the flex. Observe it. The question, Dr. Canabrava, how did you levitate it? I have the idea to use a simple air bubble behind the microspherophakia to levitate the crystalline, and I grasp it, I hold it using a 4 macro hooks. Observe how now in the green arrow, the air bubble levitates, and you can see the 4 macro hooks. But the next question is, what do you think? Everything was okay in this surgery? No, observe. I couldn't insert the CTR inside the bag, and what's necessary to do a vitrectomy and a scleral fixation. But why? What did I learn from this first case with microspherophakia? The size of the CTR. It was using to insert a 1210 CTR in a small crystalline microspherophakia. Then I looking in the Madhu instruments, I look around the world, and I found Madhu instruments in India, and they have 10.8 millimeters. And then I went for the first case, 7.8 millimeter, as you can see, crystalline, another patient microspherophakia, and then here I repeat again. Of course, less subluxated, but you can see how subluxated is this case. And 4, iris rook, the number 4. And I like to create a space to insert, look, I like to insert visco to create a space, and to the CTR go so slowly. And I don't like to use injector in the to inject the CTR. I go with a simple screw in the last eyelet of the eye, and insert it inside the eye, inside the bag, so slowly. Then I like to hydroprolapse the nucleus to the anterior chamber. And then I like, in this kind of case, to do the fake emulsification in the anterior chamber. Okay, Sergio, but in the endothelium, I prefer in the anterior chamber, then in the bag, and distress the bag. And after to remove all the crystalline and all the cortex, I remove first one side, and I use a ball hook to create a space. And as Brian told you, it's important to create a large tunnel, and then you rotate it to the anterior chamber between the CTR and the iris, and then I insert the 5-0 Prolene suture. Here, in subluxated cataract, I like to use 5-0, and in aqueous IOL, I like to use 6-0. The 5-0 polypropylene suture is 10 times more thicker and 100 more resistant than 10-0. Then the first flange in the CTS. Then I insert the CTS inside the bag. You can see, put in the position. And then I repeat the procedure in the other side. It's important to do a tunnel, then you rotate it to the anterior chamber, and you remove the 5-0 polypropylene suture, and you do the first flange for the second time in the second capsule tension segment. And then you insert, but observe, this is a large CTS. The CTS that I developed last year is a small one with 60-degree angle. I will show you in the end. And then you set it in the right position. And then you do the second flange in the first side. You cut about 2 millimeters from the base. Okay, repeat again, about 2 millimeters from the base, and do the second flange. It's important to insert it inside the scleral tunnel. At the end of my talk, I will show the problem if you don't insert it inside the scleral tunnel. Then you can insert the IOL inside the bag. And now I finish the surgery. Here, six months postoperative UBM. You can see the CTS1 and the CTS2 in the good position. And you can see the flange in the sclera. The review of the technique. 5-0 Prolene for double flanged. Here, the CTS that I'm producing with Madhu, you can see in the right part of the screen is a small one, is an angle, and 6-degree is easy, is perfect for this technique. And the flat CTS like Armia, you can produce same tilt. I had same tilts when I use a flat CTS. A 26 gauge needle for double flange with 5-0, and a 29 gauge needle for 6-0. Here are the photos, the pictures to review. And the question, is the double flange technique safe? Now I have 21 patients in 3 years follow-up, and with trauma and subluxated IOL, Marfan, microspherophakia, and it seems to be a good option for subluxated cataract. Okay, here a problem in the learning curve. It's one of my first patients in the left and the right. In the left, I did a large flange because I was afraid. You don't need to be afraid. You can do a small flange if you do a large tunnel, scleral tunnel. Then how do you treated it, Dr. Canabrava? I use 7 days in moxifloxacin, and I back for the operate room, and I cut this large flange and did a small one, and you can see the patient after the intervention. Okay, my take-home message now for my patients with subluxated cataract, Marfan, trauma. Step 1, flex. I do the phantom second all my patients. I hold the bag with iris hook or macro hooks. Then I introduce the CTR. I hydroprolapse the nucleus. Step 4, CTS in double flanged. Sergio, a dense cataract, I prefer to do intracapsular and fixate with a sclera. My Instagram, if you can follow my Instagram, every week I publish an amazing case that I do in my hospital. And thank you for the invitation. It's always a pleasure to talk with these giants on challenge case and my good friends Armia and Ashvin.
Ashvin, it's a wonderful presentation. It's like a movie. You are doing like a movie cinema. We are watching what you are doing. Really great. It's highly instructive for everyone. I like your technique. Really, you are using your mind to do a lot. This is the difference between you and others. So thank you so much, Ashvin.
Sergio, I think that was an exceptional video. I think there are a couple of questions that come up in terms of, you said that you take only 2 millimeters away from cutting that suture, and then you flange that out. Why is that 2 millimeters and why not a little bit more? I mean, it's not like this is the haptic. So is it okay if people go a little bit more or less when it comes to that cutting?
Is with the time I will do different tests. I start to 1.5 millimeters from the limbos, and then I go to 2 millimeters, and then I did first 3 millimeters from the bases. And the best way to don't do a large flange is 2 millimeters. Then two the limbos to the scleral tunnel, and 2 millimeters to the base, and you pull it, and you imagine the same distance. The bases to the limbos and the size of the flanged. If you do 2 millimeters, you not do a large flange, and you can insert it inside the scleral tunnel. The important insert bullet the flange inside the scleral tunnel. If you don't insert it, you can have endophthalmitis, you can have inflammation, you can have conjunctival erosion, like this.
Yeah, go ahead.
No. Go ahead.
Oh, the first case you showed where you placed an air bubble below the lens, below the microfocal lens. I saw Lukan's face go, "Whoa, what's happening?" So I was just asking, what was, but more on in terms of from a safety aspect. What is your take on the air bubble? I mean, have you seen what results have been like in those scenarios where you place air bubble?
In all my patients, I do it with a retinal vitrector, a retinal surgeon. And then, like in this case, I try to levitate this case because there's no vitreous in the anterior chamber. The zonula was intact, is fragility, but intact. Then I show in the green arrow, you can see how I send the air bubble, and the air bubble don't paces the zonal. Then the air bubble levitated for me. But my mistake was I used a 10 millimeters CTR. It was impossible. I tried to put one, and then I back home. What I did wrong? I did the more difficult. I levitate the ring, the crystalline. I hold the crystalline. What it didn't work? Why I did to vitrectomy and scleral fixated. Then I realized, man, it's a microspherophakia. The crystalline have 8 millimeters. It's not fit. Never will fit a 1210.
Yeah, that's a brilliant catch. Good catch you caught at home. Yes, Lukan, go ahead.
First of all, my face was not like something that I'm afraid. I was surprised that Sergio actually has done pneumatic retinopexy. We are doing that, so it is perfect, his idea. And the other thing that I really like is his 2 millimeter approach from the limbus, because this is where pars plicata ends and starts a ciliary process. When you're on 1 millimeter or 1.5, you're in the ciliary body. So 2 millimeter is, I think, is safer from point of EOP view and from point of pars plana view.
I want to say, do you know the Sioni ring? Can it go with your technique? So you put the CTR and, or you cannot use your technique with the Sioni ring.
I tried in the beginnings, but CTR plus CTS is more stable. I had tried 2 times. I saw one surgeon, I think this year, publish the double flanged Sioni ring, but not be stable because the Sioni ring is flat, and when you pull the prolen, it's tilt. Then the best way and is a CTR plus CTS is the after more than 20 surgeries the best one.
Brian, yes, go ahead, Brian.
So Sergio, brilliant. You know, we've corresponded before on this technique, and we've talked about making that tunnel. I think it's so important. It's a subtle point, but I think it's so important. So your own CTS segment you developed, I presume, but you could tell me in more detail. You know, the Ahmed CTS segment, the hole is, you know, pointing flat with the actual ring, but with your technique, with the proline needs to come in like this. Is your eyelet tilted?
Yes.
Yes, that's great.
Yes, and there is an angle. There is an angle. Of course, it's possible to do it's a Ahmed CTS, but sometimes you had tilt. Sometimes you had tilt. Yes, sometimes. But if you have an angle in the arm angle, you avoid it. You don't have tilt. Till now in my research.
Is it available in the US, yours?
No, only in India. You need to go to the ASCIS, but we understand.
Yeah, so this is a problem, Ashraf, in relation to your question, and also Brian, what you said, is it available? Unfortunately, none of these devices are available in US. You know, my paperclip capsule stabilizer also, it's not available in US, and that's because of all the FDA regulations that come in. But Ashraf, when you asked that whether Sioni ring can also be done like this, I just wanted to tell you that in 2012, I had developed with Epsilon an intracapsular device that was made with Proline also, which went out, hooked onto the bag, and then went out and did a glued IOL haptic tuck basically. So it was similar to the glued IOL, except you didn't get rid of the bag. You had an intracapsular bag fixation, which went out through a sclerotomy, the haptic. So it was not the IOL haptic, but it was this device haptic that got tucked. It was like Sergio's, what Sergio is doing now, but it was a glued IOL tuck instead of a Yamani flanging. So this was something that we developed, that I had developed with Epsilon in 2012. But then, you know, I kept working on this thing finally and, you know, fine tuning it. And then I started working with Morcher, and that's a paperclip capsule stabilizer, the present version. And I'm also working with them on developing some more things. But unfortunately, this is a question which I'm sure Sergio also gets everywhere, and I also get everywhere, is that, is it available in US? And unfortunately, I mean, this is something that probably both of us would love to be available in US and all over the world, but there are too many regulations, not only in US, in other countries as well, which unfortunately is sad, because these are beautiful techniques of bag fixation.
Thanks, Susan. Sergio, there's one interesting question, which is on what's the long-term result of this, and how long have you got
3 years. 3 years. Now I have 21 patients, but I sent a paper 4 months ago with 3 years follow-up of 14 patients. I follow 14 patients for 3 years, and my problems was one patient with a large flange. Then I need to back to the operating room and cut and reinsert. And I had one patient a large suture. The flange was okay, but after 1 or 2 weeks, the size of the flange was large. Not the flange, the suture was large. Yeah. Yes, and I need back and cut and do the flange again. But no, in these 14 patients, no endophthalmitis, no subluxate cataract. And as I told in the talk, the 50 polypropylene suture is 10 times thicker than the 10-0 polypropylene suture and 100 more resistant.
You're using flax in these cases, and when you use flax and you use a iris hook or any of these expanding devices for
no. First the flax, because I use the flax only for do the capsule racks, only to do the capsule racks.
Right. I'm only trying to understand, is that capsule strong enough to expand when you're using the iris hook or any of the capsules?
It's a basic question. I use iris hook in young people's. In patients less than 30 years old, the capsule is more elastic, and it's possible to use iris hooks. For me is the best one. But in old patients, is the best approach is macro hooks, because the capsule is not elastic, and if you try to use, for example, the case that I show is a patient about 25, or I don't remember, but you can see how the capsule was elastic.
Right. Lukan, you had a comment here.
Yeah, I have a question to Sergio. I know that you use your flange technique also to fixate IOL, no matter AO or a single piece one. Have you tried to use permanent iris retractors for that? Because I have video in my channel with fixating Envista BNL IOL with iris hooks and flanges.
Yeah, I saw your video. I don't did it, and I could to say about my experience, but I did your video, my friend. You always do amazing videos.
Sergio, how stable is the flange technique if you are going to do a vitrectomy or vitreous surgery post flange technique?
Man, the problem is, as I published in my channel in, I think, last month, the aqueous IOL is in vitrectomy is you can opacification of the IOL, because this I suggest if you have artists from crystallines, or if you have physiol from physiol pure from physiol, is a hydrophobic IOL. Is better for patient with vitrectomy. So,
I mean, how stable is the flange if you are going to do a posterior segment surgery?
They stable too in the sclera. Oh, you could. I show in this talk a video that simulates a flange in a silicone like a sclera. You can see I pull the flange, and the how can I see the silicone tilt. Did you remember this video?
Yeah.
It's so stable. When you do the sclera, man, is so difficult to remove. I have some videos to show how stable it simulates a sclera.
Lukan, go ahead, Lukan, and Brian.
I can comment on the question of Dr. Armia. It's really stable, and the issue is when you do a fluid air exchange there is no issue with sclerally fixated IOLs at all. I can guarantee that. Yeah.
Brian,
last comment, and then we'll move on.
Sergio, one last comment. You know, the 5-O-proline, I've tried to do your technique to lasso a CTR, I mean, a 3-piece IOL, which worked okay, but, you know, it's very stiff. It's very rigid. Is there a reason why you haven't transitioned all of them to 6-O? Or
yes,
is there a reason?
Yes, this is the reason. I did this modification for when you have a loop in a aqueous IOL, because is with 5-0 in this kind of fixation is difficult. It's rigid.
Okay, so we should move to the last talk. It's not the last, it's an Ashvin. So everyone is waiting for your talk. Definitely, every time I see your presentation, you impress me. You have every time you have something different, Ashvin. Really. So everyone is waiting for your presentation. I think you are going to impress us. What you are going to do if you are facing a problem post-op. So Ashvin.
I think, Ashraf, thank you so much for first having this webinar. Eva Pharma, thank you for having this webinar as well. But I'm going to show you a series of cases, and I think I'll start with this one. It's more of a congenital one. I thought it's an interesting watch, at least. If you see here, white to white, 11. It was about 12 millimeters white to white. I did start with my gluteal flaps, which is what I usually do, which I know in these cases, if you see the amount of luxation that is there, it's a bit too much. And I always try to put my posterior trocar in these cases, because you never know where that nucleus is going to, or when it might drop. Doing my sclerotomies, I usually use a 1 millimeter behind the limbus kind of a rule. May sometimes go to 1.25, but that's about it. Using one paracentesis and maybe 2 paracentesis, and that's it. But if you see, if I start my lensectomy and if I continue the way that I am doing it, I would actually lose that nucleus. So what I try to do in these cases is bimanually grasping the bag itself, just does not allow that bag to drop. And you can, in fact, see the vitreous. You can use triamcinolone. You should use triamcinolone in the beginning, in the early stages. But the advantage, what I wanted to show here is use a forceps to actually grab the bag, because a lot of times we try and do so many other things to hold that bag in place, and it really doesn't stay. Here I'm externalizing the leading haptic first, and now using the no assistant technique of Priya, which she showed earlier, which I've been using it for many years now, and I think it's brilliant in terms of I don't need an assistant anymore to externalize the trailing haptic as well. Even though you have to probably do infusion, vitrectomy, and so many things, but honestly speaking, today, if you ask me, gluteal is easier than a really tough cataract today. Honestly, this is how I feel about it, because once you get the hang of doing it, it's pretty easy. Especially in an aphakic case. I know that the complexities which Brian was talking about is very different, which is where, again, we've all reached that stage at least. But initially, I agree, use only the aphakic patients, what Priya had showed, to learn this technique. That's how I do in these pediatric cases. I wanted to... Can you guys see my screen?
Yes.
I'm not able to unfreeze my screen. I'm so sorry. Just a second. Okay. My VLC player had to give up right now. Okay, I'm going to use a different player.
So you grab your capsule when you do this. When you do this from the start, which point of your?
as soon as you start the lensectomy and you get a good grab of that bag, just go and grab any part of the capsule, and you can just make sure that you don't leave that part of it. And you can then bimanually hold the other one when you're using your left hand and swivel bit. You have to be a little bit ambidextrous in this in these cases. Moving on, I think some of the late bag dysfunctions that you find is sommering ring is one of the most important ones, if I have to add. So if you see here, this is a fully annular ring form of sommering ring, which is actually formed. And I first make my scleral flaps on both the sides, 180 degrees apart, approximately 2 by 2. I use a trocar AC maintainer, so it's a self-sealing wound. I'm making my sclerotomy is about 1 millimeter again. And I've made my main incision here to implant the lens. So the first things first, I do a vitrectomy from using both my ports. I am doing my glued intraocular lens first, and I'm not going to show that technique too much, but the most important part over here is ensure that you get both the haptics out. Now, what happens is usually the pupil shuts down. So you really have to go in and visualize this sommering ring. And a lot of times people tell me, leave the sommering ring in place. Why do you want to try and tickle it out? But it does cause a lot of tilt at times. And so I always try to remove these sommering ring. The way to remove them is first break off the zonules from periphery quadrant by quadrant. And whenever you do this, remove the iris hooks from the other side, and you can burp these ones out from the eye. You don't really need to use vitrectomy anymore. Just bring it out of the bag and put it in a longitudinal axis and burp them out. Some pieces, and I'll show that once I'm finishing that, and I kind of try to take off the bag complex wherever it doesn't look really elegant as well. Now this piece is pretty large. It didn't come out from the port. You can always go back and use a phaco probe to actually emulsify that. Only thing, make sure that you remove the iris hooks at this point. And if you see an optic edge showing up at any point, I always cover that with pupilloplasty, because otherwise I'm going to have optic, the iris and optic of that eye kind of showing up in a very, very weird way. Next day morning, you'll have a cat eye kind of pupil. The next case I wanted to show you guys was it's a special case. I think it's an interesting one, and I'm only taking time because I have to show it in a different share screen. All right, here we go.
None of the producers have any financial interest in the product.
So this case basically came to me with a post-operative case where you had a capsular phimosis, which was pretty bad. In fact, if you look at it over here, it's pretty bad. And 20/20 vision, 2200 vision from a preoperative zone. And the optic you can see is right in the middle. That edge of the optic is right in the middle of the pupil. So this was the case that I had to start off dealing with initially. I'm making my flaps. I keep swiveling between this. This is an older video, so I didn't have my marker at that point of time. But the point over here, what I'm trying to make is, I didn't know why this bag phimos and went so bad. So placing my trocar AC maintainer here and making my 2 paracentesis wounds, and that's about it. I didn't need to make a big one in this one. And I'll show you some of the complications also that I probably caused in this. I tried to open up that bag, but it was so badly phimosed that I was not able to open it up. So I really held that optic edge. And once I held it, I really saw the actual problem here. The problem here was there was already a CTR segment inside the bag over there, and then this had phimosed. So this is adding another layer of complexity to me now. I had to explant this, or what do I do? I mean, there are many ways to go. So explantation means I have to make a scleral wound or increase my corneal wound. I didn't want to do any of that, honestly speaking. I did what Lukan had showed in his case in a different way. So I basically broke off the bag at that eyelet. Luckily, the eyelet was right in front of my nose. and I was able to grab that eyelet tip. I was able to bring that out of that paracentesis wound, which I saw. Unfortunately for me, I was so proud of myself when I got this CTR ring out and I was doing my vitrectomy. I was so happy at this point that I got the CTR ring segment out, and I was going back inside, and boom, I lost my lens because I left my left hand loose. Oh boy, now I'm thinking, now what would Lukan do at this point? So I'm actually going back now and trying to put a trocar in, and fortunately for me, because of the convention currents inside the eye. So let's look at this again. While I'm pressing, what's happening is that wound is actually open and it's releasing fluid outside, and that really helped me help that convection current inside the eye bring that intraocular lens back to the space of least resistance that was the wound itself. So now I've gone back and grabbed that haptic tip. Don't yank, don't pull, don't bring it out, don't do anything. Just do a vitrectomy around that. That's the most important, I would say, to avoid traction. And the idea here was to actually use the same intraocular lens, because the lens was good. It was not like the power was wrong or anything. It was just that it was fimosed and it was decentered. And I really wanted to anyways do this before. And I was fortunate enough in this case that I was able to remove all the bag remnants using vitrectomy and using the little forceps and maneuvers that you have in your armamentarium. You really need to have the tools to remove these bag complexes. Once you're done with this, you pretty much you've pretty much stabilized the lens. At this point of time, ideally, I would have done, since I told you this was an older case, I would have done a pupilloplasty undoubtedly in these cases. So make sure that you don't have any vitreous inside the anterior chamber. I didn't do a pupilloplasty in this, but I'd love to do one if this patient ever came back for anything. So that was one more case. I do have one more case, which is a very short one, and I think it's interesting, and I think everybody would like to see that. So I'll just show that as well. I must stop share and then screen share again. Sorry, guys. So here is, no, this is not. All right. Can you guys see my screen? Okay. So this is basically a case where we are seeing glued IOL scaffold. So you see this amount of subluxation is a bit much. And I have actually gone to a vertical glued IOL. So basically my flaps are now at 6 and 12 o'clock position. So once I see this, I do a modified PAL technique popularized by David Chang, basically bringing the nucleus up into the anterior, this thing. Using the limbal and the ports that I have made sclerotomies, I am actually doing an anterior vitrectomy. Once I'm done with that, I'm actually just externalizing the haptics under this transparent nucleus. So the fortunate fact over here is the nucleus has to be a little bit transparent. Once you're done with this, you can actually tuck those haptics inside, and basically your pupil is small because I put pilocarpine already inside, and you really can just emulsify this. I didn't even use phaco power in this, honestly. It was so soft that you were able to do this without any hindrance, and pretty much becomes a very simple case where you've actually created your own posterior capsule by placing that lens. And this is the first day post-op. I wanted to show that, even though it was not a clear image, but I wanted to show that because it really helps in terms of identifying that you can do phaco even though you've created your own posterior capsule. Yes.
This is fantastic, Ashvin, the last case. How you bring it to the anterior chamber? By the flow or just a spatula and you put it in?
So I go through the sclerotomies that I've already made. I don't really need anything more than that. And it's a modified PAL technique, which was popularized by David Chang. He just basically lifts it up using a spatula. Yeah, you're right. Just a spatula.
Just a spatula. And what about you're talking the haptic of PMMA lenses. Do you find it okay to tuck the PMMA lenses?
So I would love to use what Brian is using. I'm actually a little bit envious of what Brian uses, the PVDF haptic, because they don't break. But we don't have, but I think these are exceptionally good because blue dial, to be honest to all the audiences, blue dial is a lot more forgiving than any other procedure there is when it comes to these haptic tips. And PMMA lenses have been exceptionally great for us. We use them from single piece single piece, 3-piece PMMA, rigid IOL, as well as foldable, so you can vary it as per your incision size. Yeah, so those are some of the advantages of the PMMA haptics. Yeah, go ahead, Lukan.
Yeah, Lukan.
First of all, I want to congratulate you about your marker. I bought one from Epsilon and I'm using it for Carle lens fixation, and it's remarkable. The second thing that I really liked is how you meticulously cleaned the simmering remnants. I've heard surgeons that don't do that, and this is a source of CME, a secondary glaucoma, and everything that could happen wrong. So perfect job. Congratulations.
Thank you, Lukan. Thank you. Brian.
Yeah, Brian.
I also want to echo, great talk. Ashvin, I think the pupilloplasty is so important, like you said. Sometimes with these lenses, especially, these are eyes that have been through a lot. So when you have a dislocated lens, etc., and so the pupils may not be quite symmetrical. You might have atrophy or distortion. And I think the 4th row pupilloplasty technique is so advantageous. It's so quick and easy to do, and it's so easily accessible to all of us. So whenever we're doing these techniques, if you see that the lens is, that you can see the edge of the optic, absolutely, it's the time to go ahead and fix it.
Yeah, I completely agree. So one added point I'll add to that, Brian, if you do have, and I would do this now, I didn't know this at that point of time, but if you do have a anterior capsular rhexis, please leave that, because that way you can avoid doing the pupilloplasty, because then the optic does not pop up. So if you have an anterior capsular rim, just leave it alone. Don't try and take that off. You take the posterior, whatever you want off, just leave that anterior one. That's the one that really compartmentalizes your eye. Susan.
Yeah, Ashvin, I want to ask you a secret possibly that you have. How is it that in Madras, I'm stuck here in my house, not being able to go out in Chennai, and you're sitting in this beautiful beach, I'm not sure whether it's in Florida or whether it's in Kerala, with this nice breeze around you. You're making me really jealous.
This is the dream location for everybody, even viewing right now. So I'm guessing we all want to go there at some point.
All right. Second thing, you were extremely lucky that the lens came up. I want to ask you, I know you do this particular thing. If the lens didn't come up,
which case are you talking about?
IOL, the one in which, the fluid currents just made it come up again.
If it doesn't come up, I just go back inside and do an extrusion. I would have done a 3-port pars plana vitrectomy and gone ahead and done a ECAL technique. So ECAL is something that I had spoken about and published in 2013. It was extrusion cannula assisted levitation. So extrusion cannula as a device is a device used in retinal detachment surgery usually. And when I was learning retina at that point of time, I was learning it for something else. But the frustration of actually picking up a plate haptic lens from the retina is something that only a surgeon can talk about, especially when he's not able to lift it. There's no gap to actually lift that lens, because you're going in a perpendicular fashion to lift something and you have to pinch on the retina, which is a pain. I know Lukan would add that you can actually do PFCL and stuff. But at that point of time, the frustration level was so much that you can just use this extrusion cannula on top of the optic, where you're not even anywhere close to the to the retina, and just like a vacuum cleaner on a plate, it just sucks it up and holds it in place. You just bring it up, and it's very quick. So that's something that I would do. In fact, not just that, I've done so many of these cases now that you go lift these 3-piece lenses or even single-piece rigid lenses, bring them into the pupillary zone and glue them. You really don't even have to explant them anymore if they are undamaged.
I agree. I really love that eCal technique because it's really made picking up lenses off the retina really easy. When you go in with those forceps, you always have the danger of, touching the retina and causing a bleed. And that was something that always bothered me also. But the eCal, I think, really makes it nice. And you just have to make sure that you step down a little bit on the vacuum when you come close so that you don't accidentally drop it. I think that's just one thing. And also, do you have any, I'm sure you do have some tips about exactly where to put that extrusion cannula, whether it's to the center of the IOL or to the side of the IOL.
Yeah, it's a good point actually. If you actually hold it so if this is the IOL and you're going in from the right side, try not to grab it on the right side. Grab it on the left, because the minute you supinate your hand, you'll actually hit the iris. If you supinate your hand like this, you're going to hit the iris, the vacuum breaks, and the IOL goes down again. So the only small tip is probably hold it towards the opposite side. It's easier to just watch it online and know for the viewers.
Susan, I have one question for your technique, Supracapsular. You didn't try to use your paper clip for the bag to support the bag. Then you put your IOL Supracapsular.
Yeah, Ashraf, actually, when you're looking at those cases, there are 3 things that you can do. Those kind of cases. One is you can do a lensectomy with a secondary IOL fixation of your choice. Second thing is that you can put 2 paperclip capsule stabilizers, which you can go on both sides, because we were talking about progressive subluxations there. If it is non-progressive, you can just put a paperclip and that's fine. Progressive subluxations, you would want to, take care of the delayed subluxation, which can happen with time also. So you can put 2 paperclip capsule stabilizers on either side. The beauty is that it gives you sutureless transcranial fixation. And that was also what Sergio was talking about, and which I had also started in 2012 with the Prolene device, which would get tucked into this thing. There, it was a larger device, and there also you could, that's why I went into the next phase, which was the smaller devices. But if you have 2 on either side, it takes care of it. The third is a supracapsular glue dial. It's just different options which you can exercise. It's not necessary that you have to do one of them. You think about it, think about how your case is going, and then just exercise different options. The advantage of supracapsular glue dial is that even if you are in trouble with the, you get a PCR or something, you really haven't lost anything. You just go ahead and convert it into a glue dial. Even with the paperclip capsule stabilizer, it's very easy to externalize it. So even if you put it and then you have a PCR, it's very easy to externalize it. You already have a scleral flap. All you have to do is make a scleral flap on the other side, and you just convert to a glue dial. That's the reason why I like putting in 3-piece IOLs. 3-piece foldable IOLs instead of single piece, because 3-piece foldable IOLs gives you so much leeway. Even if you're in trouble, you've gone with a particular plan in mind at the beginning of surgery, and then something goes wrong and you're not able to follow up with that plan. That 3-piece is going to save your life by just converting it into, in my case, a supracapsular, probably in Brian's case, a Yamani, and things like that. So 3-piece, I think, is a great option.
Brian, there's one question. Brian, one question to you. Like how you can actually lift the IOL and glue it in place, the same intraocular length, could that be possible in Yamani, and have you done that?
No, you guys are, 100 leagues ahead of me. I don't do this infusion, go inside the back of the eye. I don't have that experience. I think that's why glued IOL is so versatile in that situation. So you can use that dislocated lens, have your flaps made, pull it out, and then glue it in place. So I think that is a huge advantage, as you said before, about accessibility.
Lukan, you have to make.
I have done that. I lifted up a dislocated 3-piece IOL, which was implanted like 7 or 8 years ago. It was, I suppose, MA60. Yamani was okay, and 10 days later, there was a dislocation, and the dislocation was not the haptic from sclera, but the haptic from optic.
Optic, okay. Yeah, That's okay.
One last comment about Brian. In your technique, I can feel that the most important trick that you said, that you go like this and inside. All Yamani, they do like this. All the training, they go like this. This is a curve and this is straight, as you said. But if you go like what you said, straight, and you slide to the curve, this is the most important point you said in your presentation.
Thank you. To Lukan's point, just wanted to say, if the lens has been in there for God knows how long, I agree 100%. You're going to have less lens haptic manipulation with glued versus Yamani. You have to beat up the lens so much with Yamani. You're doing a lot of gymnastics potentially with it. And so that is when, if you have an old lens, it's going to break the haptic optic junction area. Whereas with glued, you wouldn't have that issue. If you're at all worried that you're going to manipulate the lens that much, I think the key would be to just take it out and then put another one in.
Okay, we should close the webinar. Thank you so much for everyone. I am so happy to be with you. It was a fantastic webinar. Everyone learned a lot about everything, how he deal with the different situations, about the IOL. It is a very wonderful webinar. Thank you, Ashvin, Soosan, Brian, Lukan, Sergio, Priya. Thanks for Eva for hosting this webinar. Thank you so much, and see you soon, my friends. Thank you.
Thank you. Bye-bye.
Thanks a lot, Ashraf.
Thank you.
Okay, bye.
Bye, Ashraf. Thank you so much, Ashraf, for having me.
Thank you, Ashvin.
Thank you. Bye-bye.
Thanks, Ashraf.
Bye-bye. Bye-bye, Brian. Bye-bye.